Good afternoon, everyone. We're going to call this meeting of Health and Human Services to order. And at this time, we have 4 agency reports that we'll be reading out. We'll start with the Maryland Health Benefit Exchange with Ms. Victoria Martinez.
Thank you, Mr. Chair and members of the committee. My name is Victoria Martinez, and I'll be presenting the Maryland Health Benefit Exchange budget analysis. The Maryland Health Benefit Exchange provides a marketplace for individuals and small businesses to access affordable or no-cost health coverage. On the first page, you can see the fiscal 2026 allowance increases by $31.6 million, or 4.6%, for a total of $718.7 million. Exhibit 1 on page 3 provides an overview of the agency's spending. Most of the budget, 83%, goes towards reinsurance payments, and an additional 4% goes towards the Young Adult Subsidy Program. The remainder of the budget includes 6% for information technology and 7% for administration expenses. And Exhibit 2 on the next page shows the breakdown of these expenses. Exhibit 3 on page 5 shows what is driving the $31.6 million increase. The largest change is a $30 million increase for payments within the reinsurance program. And aside from the reinsurance program, there was limited overall change. In terms of personnel that's discussed on page 7, there are 6 new regular positions in the fiscal 2026 allowance. These positions support consumer assistance and were brought in-house from MHBE's Consolidated Service Center. Considering the fiscal outlook and that these positions are funded in fiscal 2025 using available resources, DLS recommends reducing operating expenses by $267,000. Moving on to the first key observation that begins on page 8. This first key observation discusses the reinsurance program and forecasted funding. The reinsurance program was established in 2018 to address rising health insurance premiums in the state, and MHBE receives federal pass-through funding to support the program. Exhibit 4 on page 9 shows a sample monthly premiums. The individual market rates continued to increase for plan year 2025, but premiums remained significantly lower than prior to the program's implementation in 2019. And Exhibit 5 on page 10 shows the average individual market premium change, showing that the yearly growth in the cost of the premiums has also decreased since the program's implementation. Exhibit 6 on page 11 shows the actual and estimated reinsurance costs and federal pass-through allotment. Total costs in calendar 2023 were about $59 million more than in 2022. Reinsurance program costs continue to exceed federal pass-through funding, requiring the use of more provider assessment funds. In 2026, reinsurance costs and federal funding are expected to decrease due to fewer people qualifying for an advanced premium tax credit with the end of enhanced federal subsidies. Exhibit 7 on page 12 provides an update on the estimated closing fund balance of the federal pass-through dollars and state provider fee, showing a high enough balance of funds from the provider assessment to ensure program solvency through the end of the waiver period in 2028. The second key observation, which begins at the end of page 12, discusses the Young Adult Subsidy Program. Legislation created the program for 2 years, for 2022 and 2023, and the program was extended through 2025. MHBE submitted a report on the program in December 2024, which found that the pilot program increased young adult enrollment and reduced the uninsured rate among young adults. Exhibit 8 on page 14 shows enrollment in a health plan by age in 2024 and 2025. Enrollment increased in all age group categories, including by 21% in the young adult age group. The fiscal 2026 allowance includes $26 million for the young adult subsidy program. Considering that the subsidies through the program are only authorized through calendar 2025, and for only half of the fiscal year, DLS recommends adding language that makes $13 million of the funding contingent on legislation that extends the availability of subsidies into calendar 2026. The third key observation, beginning on the bottom of page 14, discusses enrollment in a qualified health plan through the Maryland Health Connection. Exhibit 9 on page 15 shows that there was about a 16% increase in enrollment from 2024 to 2025. The 2025 plan year was the first year that individuals who have a deferred action for childhood arrivals immigration status were able to enroll in a plan through the health insurance marketplace administered by MHBE. And MHBE reported 249 DACA recipients enrolled in a state health insurance plan for the 2025 plan year. The last key observation, beginning on page 16, discusses the findings of a legislative audit of MHBE released in January 2025. 5 of the 8 findings relate to Medicaid eligibility and the MHBE fund. Exhibit 10 on page 17 summarizes the audit recommendations and MHBE responses regarding these findings. And MHB reported having completed corrective action for 2 of these 10 recommendations, but disagreed with 4 of the recommendations. Page 18 discusses our recommendations. I've already discussed the first and the third recommendation, and the second recommendation is annual language requesting a report on the reinsurance program costs and forecasts. And with that, I'll end my presentation, and I'm happy to take any questions.
Thank you, Ms. Martinez. Seeing no questions, we'll call up the director.
Good afternoon, Chair McCray and committee members. Ready for me to proceed? Thank you. For the record, I am Michelle Eberly, the Executive Director for Maryland Health Benefit Exchange. With me today, filling in for our CFO, Tony Armiger, who unfortunately is down with COVID, I have our Deputy CFO, Tishma Delegard. We'd like to start by thanking Victoria Martinez, who for the last couple of years has gathered a lot of information and asked all the right questions to fully understand MHB's operations and to present our budget. Our team works very hard each year to be effective and efficient with our resources, and I'm privileged to be here today to provide a brief update and answer the questions raised in the budget analysis. The budget you see before you is a reflection of the significant accomplishments Exchange has made since its inception in 2011. I'll remind you that when we were established with an annual special fund allocation of not less than $35 million to fully fund the Exchange administration and operations. That special fund allocation was reduced to precisely $32 million in fiscal year 21. And for the last several years, we have required general funds to fully fund Exchange administration and operations. The very large reinsurance fund is strictly pass-through dollars and does not support our administration of operations. There is a small, I believe less than $100,000 that does go for some actuarial work for the reinsurance fund. So in essence, we have a small budget on which we provide services to 1 in 5 Marylanders. This past year was another hugely successful year. The backbone of our work is Maryland Health Connection, the technology platform where Marylanders apply for health, dental, and vision coverage in both private and public health plans. In your written testimony, I included a link that is linked to our 2025 IT roadmap presentation, which we made to our Board of Trustees in January. In this presentation, our CIO relayed many of our accomplishments for 2024. I'm going to give you just a few. We integrated our chatbot Flora with generative AI, enhancing responses for consumers, successfully addressing 650,000 queries in 2024. That prevents calls from going to our call center where we pay $8 or $12 a call. We enhanced the Social Security number verification process using robotic process automation, automatically verifying 3,000 documents. That again saved a human from having to look at that and spend time and delaying the processing of applications. We implemented an AI-powered call center agent handling, which has handled 38% of consumer password resets. And this was just since December 6th. So again, trying to eliminate those calls out of the call center. We enhance our user experience in the consumer portal, improving customer service. We enabled Broker Connect capabilities on our mobile app for more than 1,000 brokers, allowing consumers to get connected to a broker within 30 minutes to get health coverage. And we migrated 10 out of our 11 HBX, Maryland Health Connection, lower environments from MD Think to MHBE AWS, targeting potential cost savings of $750,000 per year and streamlining our operations. And finally, we built a new portal within MHC for hospitals to apply for Medicaid eligibility for deemed newborns. All our technology developments, in fact, all the work we do, is looked at through the lens of how can we improve the consumer experience, how can we reduce administrative costs, and how can we achieve better outcomes. Beyond technology, customer service is where we spend most of our dollars. This includes our call center, connector entities, outreach, appeals, and constituent services. Last year, we successfully completed the Medicaid public health emergency unwinding. It has had a long tail, and our call center is still feeling that pain. However, from an enrollment perspective, we help Marylanders remain in their Medicaid coverage or enroll in a private health plan if they were eligible. At our February board meeting, we presented a report, and I've included that link in your written testimony as well, on 2025 private pay enrollment analysis from the end of our open enrollment period. We are proud to report that we had a new record of enrollments, nearly 250,000 at the end of January. This is the 7th consecutive year of enrollment increases on Maryland Health Connection, up 56% since the pandemic. And we saw an 83% increase in enrollees who previously had Medicaid from pre-pandemic levels. The exchange was that safety net for Marylanders losing their Medicaid coverage. The area we focus on to spend our marketing and outreach dollars also continues to be successful. Enrollment by Hispanic consumers grew 25%. Our Black community enrollments grew 23%, and our young adult population 21%. While we do exceptional work, we do have challenges. Two areas have been significantly affected recently: our call center and our fulfillment costs. These are both directly related to services we provide for income-based Medicaid enrollment. Completing redeterminations for 1.4 million Medicaid recipients significantly impacted our call center operations. As I mentioned earlier, the tail was much longer on the unwinding, and the final reconciliation is still ongoing. That, along with recent federal activity around the future of Medicaid, continues to put pressure on our call center. In addition, a change was required in mailing paper notices to Medicaid consumers that increased our fulfillment costs significantly. We have worked with our partners at MDH to cover the additional costs of notices, and we are looking at ways to contain call center costs to stay within budget for this fiscal year. Before I move on to the questions raised in the budget analysis, I will comment on the state reinsurance program. This fund is made up of pass-through dollars and a carrier assessment. The carrier assessment for the first year was 2.75% and then reduced to 1% for remaining years. The reinsurance fund pays a portion of claims for insurance carriers participating in the individual marketplace. This allows the carriers to reduce premiums for all individual marketplace consumers. The exchange does not use any of these state funds for its administration or operations. We administer the funds to stabilize the entire individual marketplace. Should the federal government or the legislature eliminate or remove any of the fund dollars, it will destabilize the entire individual marketplace. Right now, the state reinsurance program is in place and solvent through December 31st, 2028. Now, onto the budget. We are very appreciative of the increase in state PINs for fiscal year 26. We operated with 67 state staff for many years, and we're finally able to add 6 state staff last year for our IT services. With your support, we will add 6 state staff this year for our Consumer Assistance Program. Historically, we have had very little turnover. We work very hard on living our values of diversity and inclusion, innovation, collaboration, and being ethical. And we are rewarded by the longevity of our staff. And I believe our turnover rate is 1%. It's very, very low. So addressing the specific questions, on page 7 of our report, DLS recommends reducing operating expenses within MHB by $267,761 in general funds for savings achieved in the call center contract by bringing those in-house 6 call center workers. As I mentioned earlier, the call center costs are significantly higher due to Medicaid call impact. However, we are seeking ways to stay within budget, and should our general funds be reduced by this amount, we will accommodate for that in our call center reductions. On page 14 of our report, DLS references the very successful young adult subsidy program, stating, consider that the subsidies through the program are only authorized through calendar year 2025, and for only half of the first year, DLS recommends adding language that makes $13 million of the funding for the program contingent on language that extends the availability of subsidies into calendar 2026. We can certainly do this. I will let you know that legislation is in the process with identical cross-file bills, SB 5 and HB 297, that have both passed their chambers and are crossing over to the other chamber, and both had favorable reports for continuing this program. OLA legislative audit findings are presented on page 16. The audit was initiated in June 2023, and we received the final report in January 2025. The audit period was March 9, 2020 through June 30, 2023, which was right during the pandemic and the public health emergency. Exhibit 10 on page 17 clearly lays out the OLA audit recommendations and MHB's response. On page 16, DLS states MHBE should provide an update on any additional corrective action taken since the audit was published in January 2025 and how it works with MDH to ensure that it is following MDH policies and federal regulations regarding eligibility determinations. I will speak to each finding briefly. Finding 1, which stated MHB did not request supporting documentation from applicants who reported having 0 income when state wage records reflected the applicant had income that exceeded the Medicaid income threshold. So MHB implements eligibility and enrollment policy as directed by the Department of Health, the state's designated Medicaid agency. MDH has an entire unit that works with the federal government to interpret and implement Medicaid policy. CMS allows applicants to attest to 0 income without further income check, and MHB followed this policy as directed by MDH in compliance with CMS. We anticipate that we're likely to see federal policy changing regarding Medicaid under this new administration, so we anticipate there will be more changes coming forward. Finding 2, MHB did not ensure that it used the most current income data in its verification process, resulting in inaccurate enrollment determinations for Medicaid applications. We utilize the Department of Labor Beacon system. It's the new system for income data. And prior to that, we used the MAB system. We did find, and we are very grateful that OLA found this, there were certain limited situations where the file that we were utilizing was not the current wage data file. It was a previous quarter of wage data file. We actually have a system change that will be deployed tomorrow on the February 28th that will correct this limited situation to ensure that most current data is always selected. The third finding, MHBE continues to rely solely on state wage records to verify income of certain applicants, even though this excludes many types of applicant income. This is a repeat finding, and we did have this 3 years ago. We've spent a lot of time with our partners at MDH, looking at the language of CMS, looking at how we do wage verification, and we do it in a multi-step process. So Medicaid looks for what the wage is on that particular day. So we look at what's in Beacon, which is quarterly data, and then if there's no data in that, we go to the IRS system, which is obviously last year's tax returns. So that could be up to 24 months old. We just have a disagreement with using the IRS data all the time, which we know is older data than Beacon. And we've gone round and roundabout on this, and the cost if we were to ping the federal system for every single Medicaid, 1 million Medicaid enrollees is really exorbitant. So,
Madam Director, I just wanted to acknowledge that we do have your written responses today.
Excellent, okay. And so then I will just finish by thanking you for this opportunity to discuss our budget requests, and I'm happy to answer any questions.
Madam Director, just one question. I'm glad that you elaborated on finding 3, and like a number of the findings, you all kind of acknowledge ownership. You said, hey, this is not the direction that we're going. It was finding 1 and finding 3 that kind of threw me off a little bit. Obviously, you have to cross-pollinate with another agency is what you were recognizing in your respective testimony. But it also felt like a non-answer or like maybe a disagreement, like you said. Definitely we're finding 3. Are you all discussing this with OLA in reference to the disagreement in finding 3, and then the one for finding 1? Is that disagreement, or is it just because it just felt like a non-answer?
So finding 3 is a disagreement, and I think what they've asked now is that to our response that we did not give them the cost of doing the study. So we can certainly do a cost of doing the study, and we discussed that in terms of if we got IRS data for every single Medicaid member, the cost to do that, and then it would also delay the processing of the Medicaid application, and it would require staff involvement to do that. So we can absolutely do that study and see what the cost is. But to the point of, and again, I would request that we have further discussion with our Medicaid agency that sets the policy, but we are following the policy as has been directed by CMS and by our state Medicaid agency.
Madam Director, seeing no questions, I did want to lean in and say thank you for what you all are doing with the Young Adult Subsidy Pilot Program. It seems like it's doing a lot of greater good within our great state of Maryland, and also the reassurance program. Just wanted to lean in and say thank you for that. Thank you, but not only yourself, but the respective team from that standpoint. And Ms. Martinez, just thank you for always looking into, elaborating, and educating us on the respective agencies. Colleagues, at this time, we'll move on to the second agency readout, which will be Department of Human Services, and we'll have Ms. Natalie Andrade.
So I'd say Natalie couldn't make it today, so unfortunately you're stuck with me today. My name is Ann Braun with the Department of Legislative Services. But as you said, today I'm presenting the budget analysis for the Department of Human Services Child Support Administration. So on page 1, you'll see that the fiscal 26 budget increases by $7.7 million or 7.6%. That brings the total budget to about $109.4 million. On page 3, Exhibit 1 shows a breakdown of the fiscal 26 budget. As you can see, personnel expenses account for the largest share, about 59% of the budget, primarily supporting local child support offices. About 18% or $20.1 million is allocated to cooperative reimbursement agreements with the state's attorney's office, magistrate office, and sheriff's office, covering the federal share of child support enforcement activities, while the state share is provided separately. In Baltimore City, child support services are contracted to a private entity with $7.9 million allocated for this purpose. On page 4, Exhibit 2 shows the key changes in the budget. As you can see, the $7.7 million increase from the fiscal 25 working appropriation to the allowance is primarily due to a $5.5 million rise in cooperative reimbursement agreements, aligning the budget with expected costs. The fiscal 25 appropriation appears lower because some contract expenses were prepaid in fiscal 2024. Additionally, $196,000, about that, the increase is attributed to adding the Allegheny County Magistrate's contract, and salary increases also contribute to the overall growth. On pages 5 and 6, this begins a discussion of the Child Support Reinvestment Fund. This fund is composed of federal incentive payments based on a performance measures that are set by the U.S. Department of Health and Human Services. Exhibit 3 on page 6 shows that this fund has seen overall revenue and expenditure growth through fiscal 24. You can see that revenues increased from $9.1 million in fiscal 2018 to $20.7 million in fiscal 24. Furthermore, DHS projects revenues of $11.5 million in fiscal 25 and $11.4 million in fiscal 26, as outlined in the budget books. And so DHS is asked to comment on the projected decline in revenues for fiscal 25 and 26 compared to the peak seen in fiscal 23. Specifically, DHS should explain whether this decrease is due to changes in federal reimbursements, lower collections, policy shifts, or other factors impacting the fund's revenue streams. Although revenue from the Child Support Reinvestment Fund was anticipated, the fiscal 25 budget did not include these funds. While using them would preclude federal reimbursement, not using them increases overall state spending. The fiscal 25 budget bill reduced $10.75 million in the child support state program, assuming these funds would be used. And the action also authorized a budget amendment to replace the reduction with special funds. However, DHS has not processed that budget amendment, and for the second year in a row, the fiscal 26 budget omits these funds with no backfill of general funds. DHS acknowledged the omission and is working with DBM to resolve it. And so DHS should provide an explanation for not processing the amendment and clarify the impact of this omission on the program's operations and funding levels. On page 7, the personnel section details a reduction in turnover expectancy from about 11% to 9%, with 54.6 vacant positions as of December 31st, 2024. While recruitment efforts have been made, 6 positions have been vacant for over 1 year. On page 8, the key observations section begins with a discussion of child support performance measures. The 2024 Joint Chairman's Report required DHS to submit 3 reports on statewide and local performance for 4 federal incentive goals, but DHS has only submitted 1 report. This limits the analysis presented in this section, and additionally, DHS did not include actual federal fiscal 24 data in its managing for results submission, and so that further restricts the availability of performance data. Exhibit 4 on page 8 shows that as of June in federal fiscal 24, statewide performance remained stable for cases with support orders, but declined in current support collections by about 1.97 percentage points. Paternity establishment and arrears collection saw slight increases of 0.74 and 0.57 percentage points respectively. However, none of these metrics met the state's fiscal 2024 goals. DHS should provide updated and accurate performance measures as of December 2024 to ensure a comprehensive understanding of statewide and local progress toward federal incentive goals. Given that only one of the 3 requested reports has been submitted and the MFR measures which are all federally required performance metrics, were not reported with actual figures. DHS should also clarify its plans to meet reporting requirements and address any barriers to timely data submission. The second key observation begins on page 9, and this presents an update of the driver's license suspension amnesty program. In August 2024, CSA launched this program to help non-custodial parents resolve license suspensions related to child support. Participants could meet with caseworkers to arrange payments, modify orders, or enroll in employment programs. If approved, they received a compliance letter for the MVA to reinstate their license at no extra cost. Between January and August 2024, more than 21,500 non-custodial parents were eligible, but only 1,127 participated, or about 5.2%. These participants collectively owed $283.5 million in child support, with an average arrears balance of $13,147 per non-custodial parent. However, only $594,000 was collected, which is about 0.2% of total arrears, and just 19% of participants made full or partial payments. The program also led to 106 modification requests, indicating some non-custodial parents sought long-term adjustments. Despite low participation and minimal financial impact, the program effectively reinstated driving privileges, with MVA issuing compliance letters to all 1,127 participants. However, given the large number of eligible non-custodial parents who did not participate, DHS is asked to comment on any barriers to participation and is asked to explore strategies to enhance outreach and effectiveness in future amnesty programs. To conclude, on page 10, the DLS recommendation is to adopt committee narrative requesting 3 child support performance reports. And with that, I'll conclude the presentation. I'm happy to try to answer some questions.
Thank you, Ms. Braun. And seeing no questions at this moment, I'd like to call up the agency. Deputy Secretary Kenitra White and her team.
Good afternoon, Chair McCray and members of the committee. For the record, I'm Kenitra White, and I serve as the Principal Deputy Secretary for the Department of Human Services. Thank you, Ms. Braun, for standing in for Ms. Andrene. And with me at the table today, I have Jonas Johnson, our Executive Director for Child Support Administration, as well as our Acting Chief Financial Officer, Jessica Smith. In our audience, we have members of our leadership team, including Dr. Tanisha Sanders, who is our newly appointed Director of Charles County Department of Social Services. Chair, you have, and committee, you have our written testimony, so I'd like to highlight a few things and then go right into the issues that were in the analysis. The Maryland Child Support Administration works with parents to provide financial, medical, and emotional support to their children so that they can grow and thrive. In federal fiscal year 24, CSA served over 150,000 families and collected and distributed over $482 million in child support payments. Families previously participating in our temporary cash assistance program took home $71 million last federal fiscal year, providing a baseline of financial stability for children. This year, we will celebrate the 50th anniversary of the Title IV-D Child Support Program. The purpose and function of child support programs have evolved since first authorized in 1975. Our work through CSA is meant to invest in and support families, not punish them when they're trying to make ends meet. We utilize the tools at our disposal as engagement tools to facilitate parental support and work to support those who are unable to pay. You may remember it used to be the Child Support Enforcement Program, and we took enforcement out because we are looking to engage our families and not punish them. For example, in August 2024, we hosted our first statewide driver's license suspension amnesty program, as was just mentioned in the analysis. As highlighted, over 1,100 driver's license were reinstated, and over nearly $600,000 was received in collections. We've administratively exempted parents from their driver's license suspension program when they have wage attachments in place, even if full obligation has not been met. We're taking a holistic view of the family and supporting non-custodial parents who are intending to pay child support, but who are not able to pay child support. We will continue to develop new methods to increase engagement and assist non-custodial parents with providing support for their children. In this year, we will host a series of statewide activities, including expungement and resource fairs for both custodial and non-custodial parents, and we will work to increase education and enrollment in our parent incentive programs to help non-custodial parents reduce their state-owed arrears. We continue to work with our community-based programs in order to support non-custodial parents who need job skills, employment opportunities to financially and emotionally support their children. We are committed to creating a more equitable child support program to strengthen families and ensure children have the support they need from both of their parents. Now we'll turn to the responses in the analysis, and I'll ask my colleague Jessica Smith to address the first two issues.
Good afternoon. In response to the first question of the projected debt decline in child support reinvestment fund revenues, a portion of the child support reinvestment fund was inadvertently omitted from the fiscal 2025 budget and proposed fiscal 2026 budget. We request that the fiscal year 2025 appropriation and fiscal 2026 allowance be restored to the fiscal 2025 target totaling $20,050,163 to align with the current revenue projections. In response to the second response of not processing the budget amendment to replace general funds with special funds from the Child Support Reinvestment Fund, the Child Support Administration is federally mandated to provide services supported by the Child Support Reinvestment Fund and will continue to do so in order to support the families we serve. The appropriation for this purpose was inadvertently omitted from the fiscal 2025 and fiscal 2026 budgets. We are working with the Department of Budget and Management to address this omission and utilize the appropriate budget corrective actions.
Now I'll ask our Executive Director, Jonas Johnson, to address the rest of the issues.
Good afternoon, Chair McCray and members of the committee. I would like to address the question that had to do with the three requested reports. One of the two overdue reports, the September 24th performance report was submitted on February 21st, 2025. The December 24 performance report was submitted on February 22nd of 2025. We will work with the Department of Budget and Management to update our MFR measures. In our written testimony, you can find the latest performance data for federal fiscal year 2024 and the first quarter of federal fiscal year 2025. We are happy to report that we have met two of the goals, paternity and current collections for federal fiscal year 2024. As we've discussed at the previous DHS budget hearings, over the last year, we renewed our focus on ensuring that our public-facing data is consistent, validated, and comprehensive. We are committed to transparently sharing high-quality data with our partners, and we will continue to enhance our ability to do so. To address the participation of our statewide amnesty program, past amnesty programs, including our 2024 program, have had two principal barriers. Some non-custodial parents fear engaging with the local child support office due to the perception of arrest or other harm, and we may not have the last known address for non-custodial parents. We are addressing the first barrier with public outreach campaigns and working with community-based organizations to decrease the fear. For contact information, we focused on updating our contact information as we receive new information, such as through returned mail, court updates, and other locate resources. We are also diversifying the way we communicate with our customers to provide notification via email, text, and through the consumer portal. For the last question regarding the performance reports, we concur but request an adjustment to the report due to dates so that we can receive relevant information and analyze the data. The requested dates are included in our written testimony. This concludes our testimony, and thank you for your time. We look forward to your questions.
Yes, ma'am. Madam Deputy Secretary, just a couple questions. It wasn't clear to me in reference to the 5 positions that were vacant last year for more than a year. It looked like 1 was filled and then.
6 positions, Chair, and 3 are currently filled, and 3 have active recruitments. 1 of those 3 we redeployed from someplace else and put to one of our other child support offices because we have a person that's long-term out. So we have redeployed one of the long-term vacancy positions to that office.
Got it. It's hard for me to say this, but I think it need to be said because we have an oversight space from here. In reference to the reports that's due, I know that you all value DLS because you start your comments off every day speaking to how they value DLS and the work that they're doing, but it doesn't show that value, obviously, when the reports come in a week before the respective hearings, and I hope that we can do better with that information to be able to help us do our job a little bit more efficient.
I completely agree with you, Chair.
Yes, ma'am.
And
Thank you.
apologize for the lateness of the reports. And
Yeah.
we
And
are committed to doing better.
I appreciate you. The third one was in reference to the driver's license amnesty program. Just salute to you all. I think that is phenomenal work that's doing. I think that you acknowledge from a deeper reach that we could be doing from that standpoint. But I do ask the question, like, are you all working with the partner agencies that may have someone else's information that may be in your system that you're trying to target, even though they have the wrong address within you all's? Like, is there any type of collaboration with partner state agencies to try to figure out this, whatever it is, the way we can increase the percentage from that 5%?
We do partner with our community-based organizations. So when an individual comes in to seek assistance from, I'll give you an example, the Center for Urban Families, CFUF, and they come in as a client of theirs, we have co-located our staff there in order to be able to assist those customers who have a fear of coming into our local child support office. And in doing so, they are able to determine what the needs are. We are able to also get updated address information. If they are currently unemployed or underemployed, we are able to suspend certain enforcement actions to get them back on track. So we are very, very proud of that program, and we are looking to extend that, or expand it, I should say, to other community-based organizations. But baby steps, but that is where we are focused right now as far as outreach, because as we know, sometimes our non-custodial parents are afraid to come into our local offices, and they are fearful of arrest and so forth. So we are going out to the community to reach them.
Okay. Seeing no questions, I just want to lean in and just salute you all for the work that you are doing, especially around the driver's license amnesty program. I'm going to start following that a little bit more, a little bit closer, because I do think that it's great work. And just wanted to lean in and also say thank you. I think the first sign of leadership is taking ownership. So I just say thank you for taking ownership of where we can do better. And Ms. Braun, not to be forgotten as Ms. Andrade, I just say thank you for helping us get a better understanding of the respective agency. Colleagues, we'll move on to our third hearing, which will be Department of Human Services, Office of Home Energy, and we'll have Courtney A. Thomas Winterberg. I apologize.
Chair, do you want us to stay or you want us to?
If we can call up the public, you can take a seat and we'll call it the public testimony. Colleagues, I apologize. There was folks that wanted to give public testimony in reference to this respective and that would be Stanton Owens from AFSCME Local 112. Thank you, Senator Zucker.
Good afternoon. My name is Stanton Owens. I work for Maryland Department of Human Services in the Office of Child Support, and I am a member of AFSCME Local 112. Thank you for the opportunity to speak on agency's budget today. Today, I want to highlight a critical issue that impacts both the families that we serve and the dedicated staff working within our system. Our offices are facing significant understaffing, with many employees leaving for better paying and less demanding opportunities in the private sector. This ongoing exodus only adds more pressure on the remaining staff, further straining an already overburdened system. As more staff members depart, the remaining employees are left to shoulder the large caseloads, leading to a growing workload that is overwhelming. This, in turn, causes burnout and affects the quality of service we are able to provide. Managing these large caseloads while also handling the demands of leadership responsibilities has become overwhelming. The morale of our workforce is declining, and this is having a direct impact on our ability to meet the needs of Maryland's children and families. The pressure on our staff continues to mount, making it more difficult to maintain the level of service and attention that our clientele deserves. In light of this, the 1% cost of living adjustment for state employees is a crucial step in addressing the challenges we face. Removing this adjustment would send the wrong message to the dedicated workers who are already stretched thin. These employees are vital to the success of our child support services, and supporting them with fair compensation is essential to maintaining a stable, effective workforce. We must focus on solutions that prioritize not only the well-being of the families we serve, but also the well-being of the staff who work tirelessly to meet their needs. By ensuring that our workers are properly supported and compensated, we can create a system that serves Maryland's children and families more effectively. Thank you again for the opportunity to address you all.
Mr. Owens, I think on behalf of all of my colleagues, it's important to say that we hear you, we see you, we value your hard work, we see what's going on down the street, and we want to make sure that the folks that do work for us, work for the state of Maryland, understands that level of value. So I say thank you for what you're doing for yourself, but not only for yourself, for all of your colleagues that work within DHS.
Thank you.
Thank you. Colleagues, as I had fumbled, I'm going to recover, and we're going to go to Department of Human Services, Office of Home Energy. And at this moment, we'll get the readout from Ms. Suveksha Bujel.
Thank you, Chair. On page 1, the fiscal 26 budget for the Office of Home Energy Program increases by $56 million, or 24.1%, to a total of $288.2 million. Exhibit 1 on page 5, we have the energy burden reduction for all fuel sources. In federal fiscal 2023, the average annual energy burden after receiving low-income home energy assistance program benefits was 9.1% for all households and 13.6% for high energy burden households. OHIP benefits reduced the energy burden for all households receiving a benefit by 28.8% and for high energy burden households by 25.8%. Exhibit 2 on page 6, we have the benefit targeting index. The benefit targeting index decreased to 88 in federal fiscal 2023. A benefit targeting index of 88 indicates that households with the highest energy burden saw a 12% lower benefit compared to all households. DHS should comment on the reason behind the increase in the index in recent years, given that the structure of the benefits has historically been to provide larger benefits to those with lower income. In federal fiscal 2023, burden reduction index decreased to 90, indicating that high energy burden households had a 10% lower reduction of energy burden compared to all households. DHS did not include actual data for fiscal 24 in its annual Managing for Results submission. due to concerns about reliability. Additionally, the 2024 Joint Chairman's Report requested DHS to submit a report providing information on number of applications received, the average number of days to process applications, and the number and percentage of application processed within certain timeframes. The report due on December 31st, 2024 was submitted on February 17, 2025. The report was not submitted in time for inclusion in this analysis. DLS recommends adopting committee narrative requesting data on energy assistance participation rates for vulnerable populations. DLS recommends restricting funds pending submission of a report on energy assistance application processing times and denial rates. On page 7, we have discussion on the proposed deficiency. The fiscal 26 budget contains deficiency appropriation of $30.9 million in OHIP. $22.2 million is from federal funds and $8.7 million is from special funds. The proposed deficiency includes $22.2 million from the low-income Home Energy Assistance Program, $7.8 million from the Electric Universal Service Program, and $0.9 million for communication expenses. Moving on to Exhibit 3 on page 8, we have the overview of agency spending. $270.2 million or 94% of OHIP budget supports energy assistance benefits. Funding for the USP program benefits, including both electric bill payment and arrears assistance, totals $187.7 million or 65% of the budget. Funding for the Maryland Energy Assistance Program Energy assistance benefits accounts for $82.1 million or 29% of the budget. Exhibit 4 on page 9, we have the proposed budget change chart. The fiscal 26 allowance for OHIP increases by $56 million or 24.1%, which is primarily due to the increase in Strategic Energy Investment Fund, which is about $55.6 million. On page 10, DLS is asking DHS to comment on if they anticipate any additional supplemental funding through the LIHIP allocation. On page 10, we also have discussion on the Electric Universal Service Program. Public Utilities article sets the annual amount of EUSP ratepayer surcharge revenue collections at $37 million. However, $49.3 million in EUSP ratepayer surcharge revenues are budgeted in fiscal 26 allowance, approximately $12.3 million more than the annual maximum collection amount. Including the deficiency appropriation of $11.2 million, EUSP ratepayer surcharge revenues total $49.6 million in fiscal 2025. DHS reports that the funds in excess of the maximum collection amount were an error. DHS should comment on how they plan to cover the costs associated with the deficiency appropriations, given the funds are not available. DLS notes that given the increased caseloads, the reduction in the EUSP allocations should come from the administrative expense instead of energy assistance benefits. On page 11, we have discussion on the Strategic Energy Investment Fund. The state government article requires at least 50% of the revenue received by the state from participation in the Regional Greenhouse Gas Initiative auctions be directed to energy assistance. Exhibit 5 on page 12 shows the RGGI auction revenue. The total RGGI program revenues received by Maryland from all auctions held during fiscal 24 total $214.2 million, which is the highest yearly revenue in program history. Exhibit 6 on page 14 provides a historical summary of the annual levels of CEF funds budgeted for energy assistance through OHIP. The fiscal 26 allowance includes $150 million in CEF funds, an increase of $55.9 million. Exhibit 7 on page 15 shows the estimated energy assistance portion of the CEF fund balance. Despite increased spending of the CEF for energy assistance benefits in fiscal 2026, the anticipated closing balance totals $59.1 million. DHS should comment on its plan to use the fund balance. Starting on page 16, we have the first issue that discusses the energy assistance applications. The number of applications for energy assistance increased by 61.1% in fiscal 2024, which can be primarily attributed to Chapter 207 of 2023. It raised the annual income eligibility level for EUSP to 200% of the federal poverty level. Chapter 207 also revised the criteria for households' eligibility in the OHIP Energy Assistance Program to establish categorical income eligibility. Although the applications for all assistance program increased significantly from fiscal 23 to 24, this trend does not apply to the number of households receiving benefits. Only EUSP recipients experienced an increase of 22.1%. In April 2024, funding for the MEEP and the gas arrears assistance programs was exhausted, and DHS stopped issuing new benefits under the program. This suspension of issuance of benefits contributed to the decline in recipients for both MEEP and gas arrearage assistance. Exhibit 9 on page 18 shows the energy assistant applications and benefit data. Through December 2024, fiscal 2025, applications for energy assistance have increased compared to applications during the same period in fiscal 2024. These increases indicate continued high demand for energy assistance in fiscal 25, as energy prices have continued to increase through the first half of the fiscal year. Consistent with the higher number of applications, the number of households receiving energy assistance benefits has also increased for all programs except for the gas assistance program. DHS should comment on the decline in number of households receiving gas assistance despite the increase in applications in fiscal 2025. Total benefits paid in fiscal 25 have decreased by $48.6 million or 49.5% compared to benefits paid during the same time period in fiscal 2024. Although a decrease would be expected given the decline in benefit amounts, the significantly lower benefit spending compared to fiscal 24 could indicate that not all funding budgeted for benefits will be used. DHS should comment if it is considering a supplemental benefit if excess funds remain at the end of fiscal 25. On page 19, there is a discussion on the implementation of categorical eligibility. Committee narrative in the 2024 JCR requested that DHS provide an update on the status of implementation of categorical eligibility for energy assistance program. Exhibit 10 on page 20 shows the number of households with income between 175 and 200% of the federal poverty level that were served because of the income eligibility changes implemented by Chapter 207. Exhibit 11 on page 21 shows the average benefits paid. OHIP reduced the benefits amount in fiscal 25 for the bill payment programs to accommodate the increased number of eligible households within the available funding. Starting in fiscal 25, OHIP has restructured the categories that it uses to determine benefit levels, resulting in highest benefit levels being provided to smaller groups. Exhibit 12 on page 22 shows the comparison of benefit levels between fiscal 2024 and 2025. Exhibit 13 on page 23 shows the average benefit size for bill payment assistance programs. In fiscal 2024, the average benefit for MEEP decreased by 33.1%, and EUSP bill payment assistance decreased by 13%. In fiscal 25 through December, the average benefit for the MEEP program further decreased by 74.3%, and the average benefit for EUSP bill assistance payments decreased by 59.9% compared to fiscal 2024. DHS should comment on the impact of these benefit changes given the higher utility costs and prolonged cold weather in winter of 2024 and 2025. On page 24, we have discussion on the customer service availability for energy programs. Committee narrative in the 2024 JCR requested that DHS provide a report on customer service availability for energy programs. Due to the absence of proper tracking measures, DHS was not able to provide data on response time, voicemail statistics, abandoned calls, and the number of inquiries made in person or via email specific to energy assistant inquiries. In absence of energy assistance specific call center measures, DHS should discuss the overall performance of DHS call centers on these metrics. In the report, DHS noted that system-wide challenges led to DHS pausing benefits in April 2024. DLS notes that DHS had, until this report, previously described the pause in MAPE benefits as being due to the exhaustion of funds. If the reason was due to MD Think challenges, it is unclear why DHS initially reported the pause as related to funding, or why pause would only impact the two federally funded programs. DHS should clarify the reasons for the pause and the change in explanations. Starting on page 25, we have the operating budget recommended actions. The first recommendation reduces general funds for miscellaneous personal expenses. Recommended action 2, request report on application processing times and denial rates. Recommended action 3 reduces special and federal funds associated with communication expenses in fiscal 2026 to level with fiscal 24 actual expenditure. Recommended action 4, the language in recommended action 4 restricts the use of 23 million that is included in fiscal 26 allowance that was labeled as expense for call center. DHS has indicated that was an error. The language restricts the use of that fund for energy assistance benefits to ensure the funds are used for the intended purpose. Recommended action 5, request report MFR data for fiscal 2024 and 2025. Recommended action 6 reduces special and federal funds associated with communication expenses in fiscal 25 to level with fiscal 24 actual expenditures. That concludes my presentation, and I'll take any questions you may have.
Thank you, Ms. Bugel. Seeing no questions, colleagues, I'm going to ask for the agency response.
We're back again, Chair. Good afternoon, Chair McCray and members of the subcommittee. For the record, I'm Carnitra White, and I serve as the Principal Deputy Secretary for the Department of Human Services. Thank you, Ms. Fulajel, for your analysis. Joining me at the table today is Augustin Nabaganamani, our Executive Director for the Family Investment Administration, Courtney Thomas Winterberg, our Acting Director of the Office of Home Energy Programs, and Jessica Smith, our Acting Chief Financial Officer. You have our written testimony, so I am going to highlight a few items, and then we'll address the issues that were raised in the analysis. Chair, do you mind if I close the door? The Office of Home Energy Programs provides energy assistance to Maryland households through a network of local departments of social services, community action agencies, and municipalities. 2024 was a year of rebuilding the OHEP program. During last year's session, we informed you that we were going to visit all of the local administrating agencies and learn about how the work was done on the ground from those partners. We did just that. We visited 20 offices, and we learned a lot. The LLAs told us about operational and resource challenges that impacted their ability to serve those seeking energy assistance. This included a lack of communication and consistent guidance from our office. We also learned about the local impact of the implementation of categorical eligibility, which was implemented in January of 2024. That implementation significantly transformed energy assistance process and ensured access for Marylanders who are eligible for the service by automatically considering households receiving SNAP, supplemental Social Security income, temporary cash assistance, as well as means-tested veterans benefits. In 2024, we received 243,252 applications. This represented 100,150 more applications than we received in 2023, a significant increase in the number of applications. Our local OHEP offices were unprepared for this surge in applications. It was a combination of the misalignment between our system capabilities as well as operational processes that further exacerbated these challenges. These issues led to significantly longer processing times, delays in benefit issuance, and the early exhaustion of the federal funds. During these visits, we listened, we learned, and as a result, we took action to address the challenges and to enhance our OHEP operations. The actions that we took included upgrading our technology and expanding systems access to equip local agencies with the necessary tools for efficient application processing. Just as an aside, I myself delivered scanners to some of our LAAs as we were doing these visits, providing comprehensive training and standardizing processes across local agencies to improve consistency and efficiency, implementing system enhancements to automate key functions, allowing staff to focus more on application processing, and expanding our customer relation management tool, we call it our CRM, to all OHEP offices so that we can enable the agencies to receive work orders and handle customer calls directly. We also adjusted the benefit levels to serve as many Marylanders as possible. We increased communication with our local OHEP offices and stakeholders. And then we also had a change in leadership and staffing. As you can see, we have an acting director, Ms. Winterberg. Sorry, Courtney. I just call her Courtney. Based on these efforts, we have improved our program operations, reduced processing delays, and lowered application denial rates. While in state fiscal year 24, our percentage of applications approved each month were lower than 40%. For the final quarter of the year, far below historical averages of above 60%. We're now above those historical averages in 2025. Year to date, 74% of our applications have been approved. Similarly, our denial rate spiked in 2024, reaching above 50% for both MEEP and EUSP. The denial rates are now at historical lows for 2025, below 25%. You'll see some charts in our written testimony demonstrating these trends. But we do recognize that we still have more work to do, and we're continuing to stabilize our OHEP operations, expanding access to energy assistance benefits. Our focus will remain on strengthening capacity at both our local and state levels, and we're committed to deepening our partnership with local administrating agencies. For the first time in 4 years, we've increased program budgets to enhance service delivery and meeting growing needs. I just want to publicly say that I want to thank Courtney Thomas Winterberg, who also serves as our Director of Allegheny Department of Social Services. She's taken on the dual role of also serving as the acting Director of our OHEP benefits. Courtney, before she came on with the state, ran this program in a local LAA. Her expertise has really helped us to unfold the onion, to find problems that we did not know, challenges that we did not know of, but also her credibility and her knowledge of the program, both at the state level and the federal level, has really helped us to turn the corner. Like I said, we still have more work to do, but I want to publicly thank Courtney for taking on this challenge and really helping us to dig in. Now with that, we will address the issues, and because, I'm going to have Courtney address the first two issues.
In response to DLS requests that we comment on the decrease in benefit targeting index In fiscal year 2025, we implemented a revised benefit structure to ensure that households with the lowest incomes relative to household size receive the highest level of assistance. MEEP grants are determined based on the household's primary heating fuel type and income level relative to household size. EUSP grants are calculated using multiple factors, including the average kilowatt-hour cost in Maryland, the household's primary heating source, income level relative to household size, and the household's electric usage over the prior 12 months. These calculations now follow a flat rate benefit model, enabling OHEP to more accurately predict expenditures and efficiently manage benefit allocations, ensuring that assistance reaches as many Marylanders as possible. This targeted approach enhances support for our most vulnerable families with the greatest energy burden to maximize the program's impact. In response to DHS providing data on energy participation rates for vulnerable populations, we concur.
In response, good afternoon, in response to the DLS request for if we anticipate any additional supplemental LAHEAP funding, pending any additional federal action, we do not anticipate receiving additional LAHEAP funds. OHEP will continue to maximize available resources to support eligible households within the existing funding allocation. In response to number 4, our plan to cover costs associated with the deficiency appropriations, we will monitor administrative expenses such as postage and will take steps to adjust for the cost within the limitations of our spending cap allocations. Response number 5, we are asked for plans to use the Energy Assistance Fund balance. We are currently reviewing our options, including supplemental benefits, and will provide an update at a later point.
In response to the decline in the number of households receiving gas arrearage assistance despite the increase in applications, households are eligible for gas arrearage benefits once every 5 years unless they qualify for a vulnerable population waiver. A vulnerable population waiver is for households with a member ages 2 years of age or younger, 60 years of age or older, or who has a critical medical need. And these benefits are provided up to the maximum amount. In fiscal year 25, OHEP reduced the maximum gas arrearage benefit to $1,000 to reallocate more funding towards MEEP benefits, ensuring broader assistance for households facing ongoing energy costs. As of February 20th, 2025, fiscal year GARA applications denial rates show that out of the 16,314 denied applications, 55% did not meet the minimum past due balance requirement of $300, while 38% previously received a gas arrearage benefit within the last 5 years. In response to whether DHS is considering a supplemental benefit if excess funds remain at the end of fiscal year 2025, DHS is actively monitoring MEEP and EUSP application trends and expenditures. We will review our options and provide an update at the appropriate point later in 2025. We always want to serve Marylanders to the maximum extent possible with available energy assistance funds, including through supplemental benefit grants. In response to the impact of benefit changes given the higher utility costs and prolonged cold weather, as mentioned previously, we are actively monitoring our MEEP and EUSP application trends and expenditures. We always want to serve as many Marylanders as possible, especially those who need it most with our available funds. This winter, we introduced a new crisis benefit. We will also maximize partnerships through customer referrals for the Fuel Fund of Maryland, Dollar Energy, and work with every one of our local partners to help Marylanders.
We were asked to comment on the Energy Assistance Call Center measures. As pointed out in the analysis, we weren't able to answer some of the questions around processing times for our OHEP applications. Most of that is due to how it was locally administered in our different local, and we didn't have the systematic way to do so. So since then, we have launched our new call center in August of 2024. In that call center, we have expanded as I said in the testimony, we've expanded the CRM tool so that our OHEP offices will be able to receive work orders as well as handle calls. We have developed some matrix to be able to adjust. We've adjusted our call center to have matrix, including energy assistance tracking. So we will have more data to be able to provide in 2025. In the preliminary analysis of the calls that were answered by our emergency assistance queue, over 21,000 were verified by the customer service representative as inquiry for OHAP. Overall, since 2025, we've received over nearly 1 million calls from our call center with a 58% answer rate with an average wait time of 18 minutes. We have been working with our vendor to ensure that they will achieve the customer service levels that we require of them. And in comparison to the previous, since the beginning, this month, our call center has answer rate of 87% of the calls. And just Wednesday, yesterday, we had a 99% answer rate of all of our calls with a 25-second average wait time. To the next issue, clarifying the reasons for the pause in benefits. As we've stated, the reason for the pause in the benefits last state fiscal year was due to the exhaustion of funds. We received, as I mentioned in the testimony, nearly 250,000 applications for energy assistance, and this was a return to, and we returned to pre-pandemic funding. So the increased demand for assistance and impacted the amount of families that we were able to service in 2024. Sorry if there was any confusion in any of the reports that we provided. And Jessica will handle the recommended actions.
Now to discuss the DLS recommended actions, starting on page 25. We concur with recommended actions 1, 2, and 4. We also concur with recommended action number 5, but note that the fiscal year reporting interval should be federal and not state fiscal year. Recommended action number 3, reduce fiscal year 2026 special and federal funds associated with communication expenses to level with fiscal 24 actual expenditure. We respectfully disagree in part. These FY 2026 funds are necessary to ensure that required mailings are sent to beneficiaries. Expenditures for these costs were also reported in the Family Investment Administration budget in fiscal 2024. The expenditures shown in the OHEP budget in fiscal 2024 don't reflect the full cost of postage. DHS requests that federal funds of $440,096 associated with communication expenses be included for the fiscal 2026 budget. In regards to recommended action number 6, reduce fiscal year 2025 special and federal funds associated with communication expenses to level with fiscal 2024 actual expenditure. We respectfully disagree in part for the same reasons stated in fiscal 2026 funds.
And then lastly, we note that the energy assistant application processing times and denial rates report was submitted late. Again, our apologies to our colleagues at the Department of Legislative Services. It is unacceptable that we have submitted so many late reports, and I've been talking to my team about ways for us to improve our process. With that, I think that concludes our last time that we will see you all this year for budget testimonies. I would like to say to you all, I said this in the House Committee last week, that this work that we do is hard work, but it's also hard work. And I want to thank you, as I thank them, for having the heart to do the hard work as we serve the most vulnerable populations in the state of Maryland. And with that, we'll take any questions.
Senator Hettleman.
Thank you very much, Mr. Chairman, and thank you for that last comment, and just thank you for your service and your team's service, and I know that it is hard work. I want to have you comment, and there are a lot of things here, so this might not be the best place to do it, but the Office of Performance Evaluation assessment of the agency and a couple of the suggestions that they made in that report. One, and I'll just throw out a couple of them and ask one question, but I'd like your thoughts on their suggestions that maybe we put together LIHEAP funds and the state special funds and combine those energy assistance funds to make it more user-friendly for customers. I mean, I will tell you, I am hearing about no issue more than concerns about energy costs. And I think almost all of us, 3 out of 4 of us are from the Baltimore area. And I think everybody would share that concern. So making it as easy as possible for constituents who are concerned when they open their bills and see the huge leap that their costs, the prices that have gone up, making sure that the most vulnerable among us have assistance and support in being able to pay those bills is really, really high at on my list of things to do for my constituents. So that's one thing, and which also leads into one of the other ideas was to further define how you assess vulnerability. And other states may prioritize older people, people with young children, and we don't do that in Maryland. So that's one other idea that they have put out there. The other is that we seem to be an outlier compared to our neighboring states with regard to how we use LIHEAP funding. We just focus it on heating, and that's fine this time of year, but in August, when those air conditioning rates go up and when there are other, weatherization concerns, I'm just sort of wondering why philosophically we are focused there at and not sort of the full range of services that could be provided under this funding. So I realize that's a lot, but I would love your thoughts about it. Thank you.
So I'm going to try to remember all of your questions. I'll start with your last one in terms of the focus of the heating benefits with LIHEAP. It's because Maryland has been so fortunate to have the EUSP and the RGGI dollars. We have that flexibility to focus LIHEAP dollars on the heating source and then the other pieces on the electric, which also helps to fund some of our weatherization energy efficiency measures. In terms of looking at consolidating the funding, there are a number of steps that would have to take place legislatively in order to make that happen. I think with categorical eligibility, it's far easier for customers to now apply for benefits and receive benefits. So we have streamlined a lot of that process. But in terms of the other piece, I don't know if there would be an objection, but at this point, that's not something that the department could make a difference with. Then in terms of the prioritizing vulnerable populations, Maryland has historically only prioritized the vulnerable populations through the vulnerable population waiver, which gives families and households with the children under the age of 2, children over the age, or adults over the age of 60 or critical medical needs, the ability to have a second arrearage grant within a 5-year period.
Up offline about the funding issues, and I understand that's not something you can do on your own, but would be interested in your perspective on perhaps legislation in the future.
Happy to work with you and happy to have further discussions.
Thank you. Thank you, Mr.
And Madam Deputy Secretary, seeing no questions, I think that it's a great way to end. On your note, hard work. Just thank you for your leadership. It's been a pleasure to be able to fully understand the agency's works, the strengths, the weaknesses, and what we'll be partnering on. So I say thank you, not just to yourself, but to your entire team and the folks that's doing the work. Ms. Bougel, just wanted to say thank you for always educating and leading and making sure that we have a full understanding of what's going on with the agency. So I say thank you again. Colleagues, at this time brings us to our last respective readout at this time, and it looks like it's a packed house for it. The Maryland Department of Health Regulatory, and we do have Ms. Ann Braun.
Thank you, Mr. Chairman, members of the committee. As you said, I'm here today to present the budget analysis for the health regulatory commissions under the Maryland Department of Health. This includes 3 independent offices, including the Maryland Healthcare Commission, the Health Services Cost Review Commission, and the Community Health Resources Commission, as well as the Prescription Drug Affordability Board. Jumping right into page 2 to begin a discussion on a few items related to fiscal 25. $1.5 million in general funds was added by the General Assembly, but cost containment actions approved by the BPW in July reduced this funding by $375,000. And so after this reduction, there is $750,000 provided for a grant to the Maryland Patient Safety Center to develop a public awareness campaign for healthcare workplace violence. And $375,000 is budgeted under HSCRC to be distributed to CRISP for services from Dr. First. MDH and the healthcare commissions are asked to provide an update on how much has been spent year to date of this funding. Proposed deficiencies add a net $21.5 million for the Shock Trauma Center, as $3.7 million in MEMSOF support is withdrawn, and $25 million in special funds collected through the increase in the vehicle registration surcharge is added. So then moving on to the fiscal 26 allowance, Exhibit 1 shows the largest components of fiscal 26 spending. I'll highlight here that just under $50 million, or 16%, is supported with user fees, and that supports personnel and operating expenses. The bar on the right shows that HSCRC accounts for the largest share of user fee spending. Beginning in fiscal 26, the maximum cap in user fees that HSCRC can collect will be reduced. However, HSCRC indicated this lower cap would not be enough funding to support its projected expenditures next year. And so there are departmental bills that would instead allow for a higher cap that would provide approximately $1.6 million in additional user fees. And that amount is included in the allowance. And so it should be noted that failure to pass the departmental bills would result in this shortfall in the HSCRC budget. Starting on page 4, the next exhibit shows proposed budget changes. I'll just highlight that the largest increase in fiscal 26 is $17 million for the Maryland Trauma Physician Services Fund, and that is due to receiving more funding from the vehicle registration surcharge. Partially offsetting this growth is a decrease of $15 million as the mandate for the Health Equity Resource Community, or HERC, grants ends in fiscal 2025. On page 6, there's a short discussion on the Maryland Patient Safety Center grant. Beginning in fiscal 2024, there's a $1 million mandate for the special fund that supports that grant. However, a provision in the BRFA would repeal that mandate beginning in fiscal 2026. And so the budget reduces $1 million in general funds contingent on that provision. Moving on to the key observations section, the first item relates to the Consortium on Coordinated Community Supports. Beginning on page 8, the consortium was created as part of the blueprint to meet student behavioral health needs. Exhibit 3 shows the mandated funding levels for consortium grants, and then the funding levels as proposed in this year's BRFA. There's a provision that would reduce the mandate by $90 million on an ongoing basis beginning in fiscal 26. And the budget as introduced includes a contingent reduction of that amount to level fund the program at $40 million. The next section discusses a provision in last year's 2024 BRFA that expanded the use of consortium funds to reimburse MDH for the state costs of school-based behavioral health services that are covered by Medicaid. The fiscal 25 budget included language that limits the use of that consortium funding for that purpose to no more than $12 million. Medicaid previously only covered school health services required for students with IEPs, but as of January 1st, 2025, MDH has expanded Medicaid coverage to include services provided by certified school psychologists and social workers for any Medicaid-eligible students. It's estimated that $8 million in consortium funds will pay for the state's share of this effort in fiscal 2025. And so after accounting for this spending and about $25 million in prior year funding that was carried forward from prior years, this would mean that $57 million in consortium funding could be available for grants in fiscal 25. Exhibit 4 on page 11 shows consortium grants by local jurisdiction. This shows that there are $109 million in active grants approved through the end of fiscal 2025. These grants support prevention, early intervention, and treatment, and are reported to serve more than 143,000 students. $89 million of this funding was expected to be distributed through February 2025, and MCHRC is asked to provide an update on the funding distributed, including whether any remaining funds are expected to be carried forward at the end of fiscal 25. MCHRC is also asked to discuss whether the estimated children served would not otherwise have received services or if they would have been served through another funding source. Based on the grant funding and the students served, the per student amounts vary greatly across jurisdictions. They range from $144 per student in Allegheny County to over $2,600 per student in Worcester County. Considering this wide range in provider costs, DLS questions the efficiency of the consortium grant process. The consortium's most recent RFP for another round of grant funding closed earlier this month, and awards are expected to be announced in April or May of this year for the fiscal 26 grant period. Moving on to key observation 2, this relates to the preparation for the HEAD model, which is a new federal agreement with CMS that will begin in calendar 26, and it builds on the current total cost of care model. Both models continue the all-payer hospital rate setting system and seek to control growth in healthcare costs and improve population health. The AHEAD model will include targets for limiting cost growth across all payers and targets for primary care investments. I'll just note that Appendix 2 provides Maryland's recent results under the total cost of care model. And so the next discussion is on the Maryland Primary Care Program. Under this program, there are federally funded incentives offered to primary care providers to deliver advanced services. Exhibit 5 on page 14 shows the Hilltop Institute's analysis on the cost effectiveness of this program. The Hilltop found that the program's results range from a net cost of $18 million to savings of $342 million. And so this suggests that the program was largely cost neutral or led to net savings. Under the AHEAD model, there would be multiple new primary care initiatives, including a new advanced primary care program under Medicaid, and that would start in July 2025. Another BRFA provision would establish a special fund with hospital rates assessed by HSCRC to pay for that new program. The Medicaid primary care program would operate similarly to the existing primary care program by distributing additional per member per month care management fees to participating providers. MDH is asked to comment on whether managed care organizations would retain the savings from this advanced care or if those savings would be shared with the state. DLS also recommends requesting continued evaluation of the cost effectiveness of the Maryland Primary Care Program and status updates on the new initiatives, but this recommendation was included as part of the Medicaid analysis. Moving on to key observation 3, this covers recent legislative changes to state funding for trauma centers. Some trauma center costs are covered through hospital rate setting that's regulated by HSCRC, but other costs like on-call physician rates fall outside of that authority. A commission established through 2023 legislation was tasked with assessing the adequacy of state funding for trauma centers, and legislation passed last year implemented some of the commission's recommendations. And so those are listed on pages 16 and 17. Just to highlight a few, this includes increasing the vehicle registration surcharge and distributing more of that revenue to the Maryland Trauma Physician Services Fund and the Shock Trauma Center. The legislation also required 20% of fines from certain driving offenses to support the Trauma Physician Services Fund. And then it also altered the reimbursement methodology under the fund and allows for more flexibility for the Maryland Healthcare Commission and HSCRC to make changes to how that fund is administered. For the Shock Trauma Center, as I noted before, MEMSOF support was withdrawn in fiscal 25 and it's discontinued in fiscal 26, while there's also additional revenue from the vehicle registration surcharge that is added. I will note, though, that there has been conflicting information in the budget books regarding the amount the Shock Trauma Center is expected to receive from this distribution. And so DBM and MHCC are asked to clarify the correct amount that should be distributed to the Shock Trauma Center. Budget bill language in fiscal 25 restricts funding from HSCRC pending a report that evaluates the recommendations from the commission. And so page 17 and 18 summarizes HSCRC's response. The commission found that the actual trauma costs were $44 million higher than regulated rates, but this was driven by outliers that were reported by 3 hospitals. Considering the significantly higher costs at those 3 hospitals, HSCRC reported that it would conduct 2 audits that are focused on trauma costs. And so the commissions are asked to provide a timeline for conducting these audits. Otherwise, HSCRC indicated that trauma centers are not underfunded since they maintained positive margins under their global budget revenues. But HSCRC noted that hospitals could submit a full rate review request to assess their rate adequacy. DLS found the report to comply with the budget bill language and therefore recommends the release of the withheld funds for HSCRC and will process a letter to that effect if no objections are raised during this budget hearing. Then moving on to the final key observation, this discusses the Prescription Drug Affordability Board's recent activity. The board is authorized to conduct cost reviews of drugs that may cause affordability issues, and then they would draft a plan of action with criteria to set upper payment limits for drugs purchased by state or local government or the Medicaid program. In March 2024, the board referred 8 drugs to the Stakeholder Council to consider for cost review, and then 6 drugs were selected from that list, and those are noted on page 19. Most recently, the board received approval from the Legislative Policy Committee in October for an upper payment limit action plan, and that defines a policy review process. The board is still updating regulations to match that approved plan. Page 21 shows the DLS recommendation to concur with the governor's allowance, and otherwise that concludes my presentation. I'm happy to answer any questions.
Thank you, Ms. Braun. Seeing no questions at this time, we'll call up the agencies.
Great. Good afternoon, Chair McRae, Vice Chair, and members of the committee. Grateful to be here today. For the record, my name is John Crom, the Executive Director of the Health Services Cost Review Commission. HSCRC's staff is really critical to all of our accomplishments, and I just want to thank them for everything that they do to enhance the quality of healthcare and patient experience and reduce the total cost of care for Marylanders. In the audience today are Deb Rifkin, Janice Lepore, Xavier Colo, and Mark Hoffman. Special thanks to Ms. Braun for her always thoughtful analysis. Really appreciate the hard work that you put in. I'll just spend a moment highlighting key accomplishments, but I'll take the bulk of my time to respond to DLS's observations and questions. The FY25 HSCRC budget allowance will allow the agency to continue supporting Maryland's leadership position as a state that successfully balances healthcare innovation, quality, and affordability. The budget really supports HSCRC's core functions, which focus on healthcare affordability, healthcare quality, and health equity. We continue to work closely with hospitals to ensure that we improve healthcare access across the healthcare delivery system. And the budget also allows us to conduct several legislative analyses, including our ongoing work related to facility fees and consumer financial protection. One of our key projects this year, as Ms. Braun highlighted, is managing the transition from the total cost of care model to the advancing all-payer health equity approaches and development model, or a HED model. The Maryland model, of course, benefits the state and its residents through investments in population health, transparency for consumers, and support for state healthcare infrastructure. But as the state transitions to the HED model, the proposed budget will allow us to do additional analytic work and policy work to respond to the changing needs in the hospital industry while supporting access to high-quality health care across the delivery system. So The first question is how much of the $375,000 set aside to be distributed at CRISP as payments for services from Dr. First has been spent, and will the full amount be expended in FY25? So HSCRC serves as a pass-through entity for the general funds earmarked by the General Assembly for those services from Dr. First. CRISP has not invoiced HSCRC for those costs, and it's our understanding that that is because Dr. First has not yet entered into a contract with CRISP. So based on that information, we would anticipate that the funds would not be spent in this fiscal year. Second, DLS observed that failure to pass HSCRC's user fee cap bill will result in a budget shortfall. Senate Bill 229 and House Bill 54 would remove the sunset on the current formula for calculating the cap on HSCRC's user fee assessment. So in the event that that doesn't pass, the user fees would revert back to a lower amount, and HSCRC would have to then reduce expenditures to live within the commission's available special funds revenue. As I mentioned, the budget as proposed really does allow us to do our core functions, including development and refinement of policies to improve access to care, conduct legislative analyses, and meet our increasing responsibilities under the AHEAD model. So a reduction in our budget would limit our ability to do that work or extend the time frame for some of our policy development work. Third, DLS recommends that MDH and HSCRC submit a report that contains an evaluation of the Maryland Primary Care Program and a status update related to the new Medicaid Advanced Primary Care Program and other primary care initiatives. HSCRC concurs with this recommendation. Next, DLS asked HSCRC to provide a timeline for conducting the 2 audits of trauma center costs. We are working on developing those audits, and we expect that they'll be completed in the second half of fiscal year 26. Finally, DLS recommends the release of $125,000 in special funds. HSCRC thanks DLS for its review and for the recommendation to release the funds. I'm happy to answer any questions that you might have.
Senator Heidelman.
Thank you very much, Mr. Chair, and thank you very much for being here. I have a question, and it wasn't really covered too much in this analysis, but I have you here, so I'm going to use the opportunity because it affects a number of constituents of mine and institutions in my district too, and that is with regard to Medicare Advantage and a number of hospitals that have exited the plan. And I know that one reached out to you recently about it and that there are possible ways of their getting some support. My understanding is that they all lose money because of our waiver and CMS. And I just want to emphasize that this is something that does affect probably nearly 10,000 beneficiaries in my district. And it's important. And so I want to know if you can comment on that and the request that was made of you.
Certainly. Happy to comment and highlight what we did in our last commission meeting, which was we proposed a potential program. We worked with MA plans as well as hospitals to kind of identify opportunities here. What that program would do potentially is essentially align incentives of hospitals and MA plans, right? So in other words, incentivize MA plans to reduce hospital utilization, right? Then MA plans would share in those savings. So creating that type of program, I think, is potentially a way that we can help with the financial sustainability of MA plans while also helping to support hospitals in Maryland as well. So it's kind of a win-win situation. We have a comment period coming out to get comments on that proposal. There are contingencies on our federal partners approving that use of Medicare dollars. And certainly in the past, that has been a challenge that we've had to navigate. But I think in this instance, really identifying a path forward that, that provides revenue, but does it in a way that incentivizes improved quality is really aligned with, what we've certainly heard from CMMI as a priority in their, in their assessment of MA within the state. So we're looking forward to getting comments and then working on that proposal.
Is that proposal already out in public?
It is about to be, the proposal is out in public. The comment period is about to start.
About to start, okay. Okay, and there is, obviously, you said pending okay by the feds, but there is potentially a way of paying for this that does not affect the general fund, correct?
Correct, yeah.
Okay, all right.
Or minimally impacts the general fund through Medicaid rates, so it would be minimal.
What do you expect the time frame for kind of getting the comments and then making decisions to be?
I think that the time frame for getting comments is relatively short, within the next month or so. I think the dependency on federal government engagement, I think, is unknown at this point.
No, thank you, Senator Hettleman. And Director Crum, my line of question is very similar to Senator Hettleman's. I've had a strong interest in this Medicare Advantage, or the challenges of the Medicare Advantage piece of it. And when I think of this, some of the things that folks continuously hid behind was the HID model would solve a number of these issues that we were having. And when I say issues, I should elaborate, serving low-income neighborhoods. So we've had a number of the plans that pulled out of specific jurisdictions because the cost of doing business may have been more. The state has continuously subsidized over years all of the MA plans, when I thought that they should focus on the ones that help the folks that are in these low-income neighborhoods, because it's like we move, when we move, it's all, not move as some. So I've just agreed with the posture that we as a state has taken. But just knowing that not just myself, not just Senator Hettleman have an interest in understanding what is the waiver test, how it's going to be contributing to make sure, because that's what we were promised, that the HID model would solve or resolve some of these respective issues. So if you could get back with Ms. Braun in reference to what is the timeline that you project in reference to this hitting the streets, how do you think that this would impact those jurisdictions where MA plans have currently left, and if this is going to incentivize them to come back, possibly, because that was what we were told that they were going to do. And the second one is like, as you all are structuring this, how are we leveraging it to where it helps the people that need it the most versus the folks that may have the resources or are easier to service, is what I should say, from that standpoint. And I can't express how much of an interest that we have within this specific subject.
I would be happy to regroup with Ms. Braun, and then, and of course, always happy to meet offline as well and talk through some potential options.
Yes, sir.
Okay. Good afternoon, Chair McCray and members of the subcommittee. My name is David Sharp. I am the acting executive director for the Maryland Healthcare Commission. As you may know, our prior executive director is in the retirement phase. He is winding down after nearly 20 years in job and 30 years with state service. So we wish him well. He's on leave through the end of April. Into the end of March, and then starts officially his retirement. So it's a pleasure to be here before you today to make this presentation. The MHCC thanks the Governor, the Department of Budget Management, and the Budget Committee for their support. We appreciate the help and guidance provided by Ms. Ann Braun throughout the process. You have our PowerPoint slide presentation, and while I'm not going to go through it all, I would like to just point you all to the notable accomplishment slides. You'll find that we've listed many different activities in the categories of improving access to care and addressing health disparities to support Healthier Maryland. We have identified and completed a number of activities related to improving the health of Marylanders using information on the quality and cost of care. And the last category where we've included a number of accomplishments is ensuring all Marylanders have access to quality care for a healthier future. So we'd like to call your attention to them, and I'll continue on. I'll give you a high-level overview of MHCC, and then we'll address the questions noted by Ms. Braun in her analysis, subcommittee members and chair. The MHCC is a 15-member independent regulatory commission organized around healthcare system needs. We evaluate, regulate, or influence utilizing a wide range of tools such as reports, data from primary care payers, from government payers, to improve quality, address costs, and increase access to care. The Commission's activities are directed and managed by the Commission's Executive Director. Administrative activities such as staffing, budget, and procurement are managed by the Director of Administration. We have 2 Assistant Attorney Generals that provide professional legal guidance to the Executive Director, the Commission members, and the Commission staff. MHCC is organized into 4 centers. Two of the 4 centers, one being the Health Care Facilities Planning and Development and the Center for Quality Measurement and Reporting, are centralized around healthcare provider organizations, bringing expertise and strategy together to address healthcare costs, quality, accessibility throughout Maryland's healthcare system. The third, the Center for Analysis and Information System, not only conducts in-depth varied studies using Maryland's databases and national surveys, but also has specific responsibilities relating to physician services. The last center, the fourth, being the Center for Health Information and Technology and Innovative Care Delivery, oversees activities that cut across all healthcare sectors to use health IT, support advanced care delivery, and facilitate private and secure transfer of personal protected health information among the sectors. Now I'd like to discuss the questions raised during the analysis specific to MHCC. The first question, we were asked to comment on the funds appropriated to the Maryland Patient Safety Center for the Healthcare Workplace Violence Campaign and the expenditure of these funds. The $750,000 within MHCC to distribute to the Maryland Patient Safety Center for public awareness campaigns related to healthcare workplace violence has been fully expended. This funding supported a contract to develop the campaign, including a website, digital advertisements across various social media and news platforms, and other advertisements across the state. It is our understanding that the campaign is in full swing and it's very successful. The next question we were asked to address is to clarify the amount of the vehicle registration surcharge revenue that should be distributed to shock trauma in fiscal year 2025 and 2026, and explain how the funding will be added to the budget. The numbers in the MIMSoft appendix are estimates of the appropriate amount of revenue that will be distributed to shock trauma in fiscal year 25 and 26. Therefore, the Shock Trauma Center can only spend the amount of monies actually received, not up to the estimated amount in the appendix. Again, to underscore, rather received. This is very important because driver registration fees paid to the motor vehicle registration will vary over the next couple of years, as we know that drivers can register once for a year long, 2 years, and then they can make incremental payments throughout the process. Determining the exact amount of revenue that can be received through the motor vehicle registration will be difficult to quantify right now. We believe The estimates are a good way to identify the amount of funds that will be available through the MBA. The last question, should MHCC and HSCRC should provide a timeline for conducting the 2 audits of the trauma centers and linking the MIMS trauma registry, the HSCRC hospital data set, and the MHCC all-payer claims database. So I'll talk a little bit about the work that CRISP is doing with the MIMS folks and then the connecting of the databases. MIMS has been working with CRISP to evaluate the feasibility of assigning the same encrypted identifier, it's called a master patient index, to the Maryland Trauma Registry entries and as it does to the MHCC all-payer claims database. The first of 2 issues to note is that supplying sufficient patient demographic information to ensure a valid match via the trauma registry is somewhat of a challenge. After an iterative refinement process, CRISP believes it can assign an appropriate MPI for more than 90% of the patients on the trauma registry. During this calendar year, MIMS plans to submit trauma registry cases to CRISP on a quarterly basis for the MPI assignment. The second issue to note is linking of the assigned MPI to the clinical data within each trauma registry entry, this would require a new field to be added to proprietary software. MIMS will be working with the trauma registry software vendor in the coming months after ensuring quarterly updates to acquire the MPI's work to determine the most reliable and cost-efficient pathway forward. So this concludes my comments related to the questions and our presentation today. Mr. Chairman and members of the subcommittee, I'm happy to answer any questions.
Thank you. And just for the other 2, I just want to let you know we do have the comments so you can give high level from that standpoint. I do think we want to take another bite at you, Director Crum. When you're given the timeline or you're reporting out in reference to like how you're incentivizing, can you also make sure that you speak to the ones that decided to stay? So those folks that are still serving that hard population that's bearing that cost for all of us, like what are we doing to make sure that we incentivize them to actually stay in that respective jurisdictions when the other ones fail to do so?
So we may have to work with other agencies to work on that since we don't regulate the MA plans. So if I can get back to you on that, I will.
Now, I deeply appreciate that. I just think that the $5 million that was coming on a yearly basis to the respective MA plans, that it wasn't done in a judicious way where it was targeting those folks that need us the most. I think that it was spread out, depending maybe on your size, but it wasn't on the neediest is where I would have directed those respective resources.
Yeah, I mean, I think certainly that approach of kind of the grant without having
safeguards,
kind of
belts,
safeguards, quality requirements, et cetera. That's not the approach that we're contemplating here. So I'm happy to talk about really what level of accountability is built.
And I appreciate that. I sent you a text with an article that I op-ed a couple years ago on this specific subject so that you understand my frustration, my pain around this specific issue. I want to go to Senator Jennings. I see his light is red.
Thank you. Actually, I have 2 questions. One, since we're going to go back, actually, Senator Hedelman, when she was asking her questions, it reminded me of something I was going through emails from a while ago because I'd had a meeting about this. We know the uncertainty of D.C. right now with the Trump administration, and you said, you're waiting to hear back from the feds once you turn it over to them. Who knows if they're going to approve it? I know there's some other proposals out there. I think there's a Life Bridge proposal. Is that a possibility?
I mean, we'll certainly discuss with them. I don't know that. I don't know if it changes the need to work with CMMI on the, on the proposal. But we'll certainly.
And I bring that up because I did have a meeting with Senator Ferguson and a couple others about 2 weeks ago on some stuff, and this came up, it was on the radar screen. And again, if it wouldn't have been for her question, I would have totally gone by. So please keep that in your mind, because again, I don't know what's coming out of DC, and this can't linger. We have to do something. And just kind of sitting there waiting, saying, hey, well, we're waiting on the feds, it'll take forever, because I think they're just, you see what's happening every day. I mean, it's affecting our budget, trying to pass a budget down here, so.
I certainly appreciate that. I would note that the kind of the mechanisms by which MA plans would potentially get revenue are, one, through their reimbursement formulas. That is CMS, right? So we can't touch that without their.
Okay.
And then the other would be through using essentially other Medicare dollars. So we on some level, we do need to work with them in order to use kind of the mechanisms available to HSCRC. But we can certainly, we'll certainly engage with the LifeBridge team.
Okay, thank you. And the other question, this goes back to the shock trauma. I was actually Googling research on the other question when you hit that, and I caught the end of it. And I knew that the analysis, she brought up the question about the clarification of the funding of 38.6 million or the 39.7 million. And then I heard you mention that they can't get the full funding of that. They have to get whatever actually the state brings in from the actual revenue or the car registration fee. And you discussed about, it could be the yearly registration or I thought it was a biannual registration.
So, Senator, thank you for the question. So individuals can register yearly or biannually. The assessment is tabulated for 2 years, but you could pay half of it in 1 year and half the second year.
Okay.
And they also have an ability to pay on a fee schedule. If you can't make the payments, you can make payments throughout. So there's permissiveness. So the fee went from $5 to $13, but it's not all collected at one time. So if some of the drivers who register decide to do the $5, do the half of that now, then you get half of the fund, but some might linger to the second year to pay the full amount.
Okay. All right, I understand that. So what about this 38.6 or the 39.7? What is your view on that?
So I think I need to get back to you on that because, if you would allow me to get back to you, I would appreciate it.
Thanks.
Director Carl, I just wanted to clarify, as you were talking about the tools in the toolbox, I'm under the assumption, and not you, the subject matter expert, but through the waiver, there's incentivized ways that we keep people out of our respective hospitals, and you could deploy those funds, whether it's hospitals, MA plans, different things of that nature. Am I off on that?
No, you're right, and that's essentially what we're looking at here.
Okay.
Yeah. So essentially, we'd be incentivizing MA plans to reduce hospital utilization. It would have to be actuarially sound, but then we'd look at the amount of savings generated and share in those savings, right?
Yep. So. I promise it's not a third bite at the apple. Mr. Luckman.
It's good to see you again, Mr. Chairman. I'll keep my remarks very brief. I know you have my written comments. Well, first, if I could just, Lorianne Moss and Bob Lally, if they could just show. They do a lot of this work with the consortium. Lorianne celebrated her 5-year anniversary. Jen and Michael celebrated 5 years earlier this month. Nell was with me earlier. She says hello. Of our 4 vacancies, one starts next week. Will be the director of the consortium. We're interviewing for Nell's deputy, so she's going to have a new person on board. So the vacancies will be cut in half. Not in my written response. I just want to make the point because Okay, a couple thank yous. I want to thank the administration for the allowance. Just really grateful for these resources. We're going to do everything we can to stretch them as far as we can. I want to thank Ms. Braun for her analysis as always. Concur with everything, although I'm going to get into Exhibit 4 in a moment. If I could just 30 seconds about the consortium. It's 25 members, great group of folks. Ryan Moran, Aaron McMullen from MDH rather. Appreciate it. 6 cabinet agencies serve on the consortium. It's a whole nother thing. So it's been a lot of work, and we're happy with where we have come so far. I want to give a shout out to Dave Rudolph, our chair of the consortium, not here today. He appreciates the work, former legislator, lifelong principal. If I could just give a couple of key metrics that we're following here at the consortium, and then I'll get into your 3 points, okay? So when the blueprint was amended by Senate leadership, folks will remember, we were asked to create a statewide framework of coordinated, comprehensive, non-stigmatized behavioral services. So in less than a year, 130 grants, just on 120 million obligated, and those grants are now serving 80% of Maryland schools. 80% of Maryland schools. Also, they're projected to serve about 150,000 kids, many of whom are kids that need therapy, and that, that's, these are folks who we don't want to leave behind. They need intensive services. So as I skip ahead to the analysis by Ms. Braun in Exhibit 4, the grants vary because the kids, their needs vary. Some of these grants, like in Allegheny County, they serve multiple schools and they provide prevention services and they hit a lot of kids and it's very cheap and they hit a lot of kids. Other ones are full-on therapy, what's called Tier 3 services. And a child might be seen multiple times in a week. So the cost of these services really vary. So in our respectful opinion, I think the most important yardstick is, are these kids getting better, right? And so we were thrilled, and I sent, I hope this made its way to the subcommittee, this one pager. 80% of schools served, 83% of all students, parents, and families are satisfied with the services they're getting, 83%. 80% of them are demonstrating new skills in the services that they're getting. For those that are just beginning to need services, it's called Tier 2. 77% are demonstrating improvements in anxiety or suicidality or other things, depression. And then finally, the folks that need the services the most, the vulnerable children, 70% are demonstrating improvement in specific health outcomes. So we agree with the analysis by Ms. Braun, it's accurate, but we think maybe a better way to look at this is, are these kids who are getting the services getting better? And are we on target to serve 150,000 kids? And we are in fact on target to do that. So with that, I'll end, I promise I'll be short, I'll end my oral remarks and be happy to answer any questions. And again, it's good to see you, Mr. Chairman.
Yep, no problem at all. I think I feel assured that this respective committee knows the importance of the work. I know you felt compelled to do it because of the budget conversation that's going on, but you've done a very good job of ingraining us in the work that's taking place as it was being set up, as it was being deployed, and who it's impacting. So I know the importance of explaining, but let me be clear, we also understand how this wraps into the blueprint, having the wraparound services, but also the education component. Yes, sir.
Great. Chair McCray, members of the committee. For the record, my name is Andrew York, and I'm the Executive Director of the Maryland Prescription Drug Affordability Board. As the cleanup batter of the day, I just want to thank Ms. Braun for her very thoughtful analysis and the committee for their time and support. We support this budget, and I'm available for any questions. Thanks.
Wow, it made us look bad.
Senator Zucker.
So I had a question for Mr. Luckner since he's doing a great job. So now that I can get you on the record, who was your favorite staffer from the year 2000? I'm just wondering. Well, you know what? I don't want you to answer that because I know the chair wasn't here at that time, so we're good.
Well, there's a couple that come to mind. Of course, President Company, who was my neighbor down the hall when we were having, conversation with Barbara Oakes, rest her soul. Of course, Senator Hayes was also, down the hall. So it's been good, and it's been 25 years, same employee. So very grateful. 15 here. Thanks for that, Senator.
Can always count on Senator Zucker. Colleagues, seeing no more questions, I just wanted to lean in and say to each and every respective commission, just thank you for the work that you all are doing. We know the population it impacts, and obviously you can see that we're deeply concerned about the work that you all are doing. Ms. Braun, thank you for sitting in, but more importantly, thank you for also engaging us with all of our respective commissions. Colleagues, this actually ends our HHS hearings for today, and I believe that we will see you. Say that again. Oh, yeah, you're right. We do. Maryland Patient Center. If you can pop up. And it's only two. It was Ms. Stephanie Pedito and Rhea Gupta. and, yeah, some of them were staff. Dr. Scalia. Yeah, they were agency folks. I see him. Dr. Scalia, you coming up? Oh, sure. He said, sure. Kristen, did you want to come up? JB was rooting for you.
I didn't sign up. I'm here to support family needs.
Need a lot of support.
Lots of support.
All right, anyone?
Okay. Hi, everyone. Hi, Chair. Thank you, Senators, for allowing me to be here. I'm Stephanie Petito. I'm the recently appointed President and CEO of the Maryland Patient Safety Center, and I've spent my life's work helping with patient safety across the state and actually across the nation. The legislature recognized the need for a patient safety center in Maryland, and in 2022 mandated legislation to the tune of $1 million per year for the funding, and that funding is now at risk, which means that our organization is now at risk. And so we are the only organization in practice, in regulation and legislation that works on patient safety across the state of Maryland. If not us, there's no one to do this work. And you might not have heard of us, and that's mostly because we work behind the curtain. But as you'll see in our submitted testimony, others know of us and know the good work that we do. And we have submitted letters of support from the Maryland Hospital Association, Lifespan, which is the largest network of senior care providers, the quality and safety leaders of hospitals across the state of Maryland, a Maryland Healthcare Commission commissioner, and others. And so our principal areas of focus are on reducing preventable infections and complications of care and decreasing maternal deaths and complications from pregnancy. And so we impact health equity. And these cost lives, but they also lead to human suffering and cost the system, including Medicaid, in the form of longer hospitalizations, more readmissions, the need for post-acute care and ED visits. We've shown that we can do this. We led Birth Equity Maryland. We've led an improvement initiative across long-term care to reduce infections, which reduced ED visits. And we work in other areas across the state. We support the Maryland healthcare workforce in all that we do. We implemented the healthcare workforce campaign that you talked about, and our interventions reduce burnout and help address the workforce shortage. So we affect healthcare across the state, and we respectfully request that you add in the funding.
Hi, I'm Tom Scalea. I'm the chief at the Shock Trauma Center. Last year, the trauma system and shock trauma, the only freestanding trauma hospital in the United States, were under great stress, and we spent many hours here discussing how relief could look, and in the end, the legislature voted to once again support trauma care in a real way, and I thank you. I was asked to come and spend a little time discussing what we have done with the additional funding, and I'm happy to do so. The issue we discussed was access to trauma care. And at the Shock Trauma Center, we've actually done very, very well addressing that. We increased the number of operating rooms from 6 to 8, which has increased the number of operative cases we do each day and in toto. That has led to a decrease in the length of stay of over 2 days in patients who require surgery. 2-day length of stay reduction is unheard of. We have decreased lost inter-hospital transfers by over 2/3. That's only really part of the story. In August, we went from 25 to 5. We're now down to about 1 or 2 per month of real lost admissions. Our time on capacity alert has gone down. Capacity alert is not trauma bypass. I can elaborate if you like. The state mandate is to be below 5%, and we were at 5% for a good bit of 2023. We're now down to 0.2% of the time, and when we go on, we're on for an hour or 2 maximum. We significantly expanded the programmatic services and 300% increase in the number of people receiving Stop the Bleed training, 7% increase in violence intervention participants, a new 150 people served through intimate partner violence, programs that we launched a new youth violence prevention that is ongoing. And so we feel like we have been good stewards of the additional resources. I said we would be wide open. In fact, the front door is wide open. I thank you again for your past and ongoing support and look forward to further discussions.
Thank you. Ms. Gupta, before we jump to you, just one question for Dr. Scalia. First, I just thank you because I was asking the question, hey, we did this year, we did this the previous year in reference to extra money for our trauma centers, but like, how is it being deployed? So I thank you for coming here to be able to explain and articulate how it's being deployed. Some of the reading that I believe, and this is probably self-explanatory, but I just want to dig a little bit deeper. You talked about the emergency rooms and going from 6 to 8. So I was concerned in reference to the staffing because when we were deploying the funds, there was a challenge.
It's operating rooms.
Operating rooms, I apologize, operating rooms, 6 to 8. The staffing was a big key challenge during the time when we were deploying the funds. If you're opening up 6 to 8 operating rooms, I'm assuming that the staffing challenges that we were having is being addressed because you have more access from that standpoint. But can you dig into that a little bit, and specifically around the staffing component, the nurses?
Yes, we have been, we've done very well recruiting people. I'm pleased to say the staff turnover is down. I'm pleased to say that too. And this is 8 operating rooms up from 6, so 2 additional operating rooms, 5 days a week, not 7, 5 days a week from 7 until 3. So not 24 hours, but just that addition has been able, we could get 3-4 more cases done. And if you do that Monday through Friday, we're able to accumulate a substantial increase in the amount of work we can get done.
Now, I appreciate that, and I just think as the oversight that's deploying the resources so that you guys can do great work with it, we should have the ability to articulate, hey, here's how the funds are redeployed. So just thank you for doing that.
Happy to do it.
That was my question. Yes, sir. Ms. Gupta.
Good afternoon, Chair McCray and members.
I apologize.
Oh, sorry, sir.
Okay. Yeah. Go ahead.
Okay. Good afternoon, Chair McCray and members of the committee. My name is Rhea Gupta. I'm the Interim Executive Director of Strong Schools Maryland, and I'm here today to urge you to restore full funding to the Consortium on Coordinated Community Supports. As you know, Maryland is in a youth mental health crisis. Over a third of middle and high schoolers in Maryland reported feeling sad or hopeless for at least 2 weeks in the year. These aren't just statistics, they represent students struggling, falling behind, and lacking the support that they need. The consortium was created to change that. As you just heard, in 8 months, it's provided behavioral health services to more than 58,000 students in 80% of Maryland public schools, reaching every single school system. And it's set to serve nearly 144,000 students by June. In the span of 1 year, in their first year of full functioning. Students are finally starting to receive the care they need and deserve, and schools are becoming better equipped to support them. Yet despite its success, the proposed budget slashes consortium funding from $130 million to just $40 million, not just this year, but indefinitely. That's a 70% cut to vital services at a time when demand has never been higher. Students will lose access to critical mental health support, and a proven program will essentially be dismantled. Yet, yes, the state faces a fiscal shortfall, but the simple truth is that the budget asks students, again, to bear a huge disproportional share of fiscal pain. Investing in behavioral health improves academic outcomes, reduces disciplinary issues, and saves money in healthcare and public safety in the long term. We urge the committee to restore the consortium's full $130 million funding for fiscal year 26 and beyond. Our students cannot afford these cuts, but you know that. Thank you.
Senator Jennings.
Thank you. Dr. Scalia, questions for you. With what we did last year with this money, and you just talked about the capacity expansion, I would say, at shock trauma, and most people kind of think of shock trauma as just of a Baltimore regional facility, and I would say it's statewide impact with the medevac system. Is it safe to say, with your expansion of capacity, you've been able to pull some of the sicker patients from the hospitals throughout the state through the other emergency rooms?
Yeah, absolutely, both from the emergency departments and the inpatient setting as well. And, we learned many, many, many years ago that time is an important variable if you're badly injured, right? It's the golden hour. And so the ability to get them in, but to get them in quickly, I think is key to optimizing results. We're quicker than we used to be.
And I asked that question because in Baltimore County delegation on Monday, across the hall, we just had our Baltimore County Fire Chief in, and he was talking about, the question I asked, what we've heard from our fire department is, was it 90 minutes? They've had medics sitting in Baltimore, or the local hospitals up to 90 minutes waiting to relieve a patient, or to hand a patient off to the emergency room.
That's not an issue for us.
Well, no, I get that. I understand that. But what I'm trying to say is, and I want to kind of make the point here, that by your expanded capacity, you're able to take patients from these other emergency rooms that are more sick so that the local hospitals have more capacity themselves. So I just want to confirm that.
That is correct.
As we're looking at these tight budget times, and, we make sure we keep this funding for shock trauma.
Thank you.
Thank you.
Seeing no questions, I think that it's important just to recognize each and every one of you all's advocacies in reference to the respective institutions or subject matters that you're here for, so we say thank you. Colleagues, I usually call them up in 4, but I want to make sure that I didn't miss Ms. Ann Gittes. And I just want to lean in and say, if there's anybody else in the crowd that feel an obligation to get their 2 minutes, and please come when Ms. Gittes comes.
Thank you, Mr. Chairman and committee members. I'll be real quick. I'm Ann Geddes with the Mental Health Association of Maryland here. It seemed like an important place to stress the real importance of full funding for the Consortium on Coordinated Community Supports. I just want to make a couple points. One is really the need has never been greater. The recent data from the Youth Risk Behavior Survey 2022-23 showed that 28% of high school students reported that their mental health was not good most of the time or always, and 24% of middle school students stated that they had seriously considered suicide. So the need is tremendous. Mark Luckner gave a report of the outstanding reach and outcomes that these programs are having. And I just want to add that schools are like the great place to provide behavioral health services. When students are referred for outside behavioral health services, only about 3 in 4 go to 1 appointment, and only about half go to 4 appointments. Barriers, families face lots of barriers. It's very hard for them to get a child to see an outside provider for a variety of reasons listed in my written testimony. So we really support full funding for the consortium and ask for your support. No, we have it. Thank you.
I'm glad you said no, we have it. So thank you. Colleagues, I think I've got everybody. So this now officially ends HHS's hearings, and possibly see you tomorrow. Thank you.